Namaste. Dear Dr. Makka, dear Amit, it's very, very cool to be here again. It took me a long trip to come here with some barriers in between, but finally I'm here. And I'm honored to be here in the room. I'm honored to discuss new ideas about diabetes management. And what we just heard this talk about the new chances of using sensors, of generating safety and protection for our patient, it's brilliant in the future. And I'm very sure that in 3 years from now, we will have sensors for less than $1, and we will use this to improve the quality of diabetes care for many, many, many of our patients. But Dr. Manoj and Banshi gave me a topic, remission of type 2 diabetes, overpromised or underutilized. And this is actually an interesting question. Once, are we able to lead to a diabetes remission? Imagine we would answer this question with yes, 243 million people with diabetes in India, and we could reach a remission. Actually, this would be very cool. If you talk about another 200 million in China, if you talk about big numbers of people living with diabetes in Pakistan and in Bangladesh, in the Gulf states, Saudi Arabia, upcoming in Africa, this would be an opportunity. But let's look into it. Myself, Peter Schwarz, Professor for Prevention and Care of Diabetes and President of the International Diabetes Federation, one of the coolest jobs you can have in the world, being the president of 256 member organizations. First question, if we discuss about remission of diabetes, let's think about what is the main determinant that so many people are getting diabetes. Yesterday, I met the ambassador of India in Dubai, and I was for an hour discussing with him, why are so many Indians getting diabetes? And I would say the answer is very simple. It's this. If you fry carbs at a temperature of above 129.7 degrees, you build bonds between glucose and fat. And you eat them because it's lekker if you look at this. Yeah? You get it everywhere, on every street. So then it's in our body. So and what happens with them? The body cannot break it down. The body needs energy to break this down, and it's storing it. And where is he storing it? In the liver. And this is MAFE, this is MESH, this is NAFE, this is NASH. And this generates every day if we are eating fried carbs. We could solve the problem if we would use the air fryer, but this is another technology. So remission of type 2 diabetes, what is it? There is a definition. It says below 6.5 for a certain time. I personally would say this is not a remission. Having an A1C of 6.5 is still high. It's still not normal. For me, remission would be normal. We have to keep in mind it's not a cure, and it's important. If someone leads to a remission, he had diabetes, and he have still the risk, so we have to monitor this person. But we are scientists. We have to go into understanding the pathophysiology, where it's coming from. And if we look at this scale, this is 80 years of a person developing diabetes. And you see there's glucose rising at a certain time, blue line, insulin is going up. This is the insulin resistance developed based on the visceral obesity, the green line, and the visceral fat is secreting more than 830 peptide hormones, and they making us getting insulin resistance, depression, impotence, hypertension, and so on. But there's also a new player, and this is the fat in the liver, mainly coming from fried carbs. And you see it's going up and then continuously rises. So if we think about the pathophysiology of diabetes development, the problem arises that here diabetes starts and here we diagnose the disease. So honestly, we come very, 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 very late. We have only the last fifth piece of this slide where we act as physician. And if we now think about remission of diabetes, there are two approaches. One is to act much earlier so that we prevent diabetes. This is also a kind of remission for me. Or secondly, if we are in the treatment phase, we have to totally base our interventions on the pathophysiology of diabetes development, because people living with diabetes in this range, they may only have 30 or 20% of the secretory capacity of the beta cells left. But honestly, the interplay between visceral fat and hepatic fat is driving the development of the pathophysiology of diabetes. So if we think again about remission, if I say treatment should be based on the pathophysiology, remission also should be based on the pathophysiology. What can lead to remission of diabetes? Of course, weight loss. Weight loss, weight loss. But is it really weight loss? It's the loss of visceral fat and hepatic fat mainly if you want to achieve a remission of diabetes. Of course, there are studies using an intensive lifestyle intervention, so physical activity in combination with dietary behavior change. But the main target always is if you are able to reduce the bad fat compartments, you have a higher chance of leading to a remission of diabetes. And the pathophysiology behind this is in the visceral fat, the 830 hormones increasing our risk. So I would like to say that the fat in the visceral fat is making us sick, but even more dangerous, the fat in the liver, this is killing us. And why is it? Because there are three ways of having fat in the liver. It can be the adipocyte in the liver. It can be the fat vesicle in the hepatocyte or between the hepatocyte. And all three of them have different functions. So if it's in the hepatocyte, there is a release of hepatokines, and they make cancer, and they make a very fast progression of diabetes. So getting this fat in the liver away would probably be the primary target. And there's bariatric surgery also helping us to lead to a remission. So how can we go along with all these aspects? And it was Taylor, and he has given the answer. If you have fat in the liver, you also have it in the pancreas. And maybe if I'm talking about fat in the liver, this is wrong, because the true target is the fat in the pancreas. And this destroys beta cell function. But also the opposite works. If you remove the fat out of the liver, you move it out of the pancreas, and you restore beta cell function. And what means restorage of beta cell function? It's remission of diabetes, remission of diabetes, remission of diabetes. So how to get the fat out of the liver? It's fasting. If you fast for 2 weeks without eating anything, so no energy, no kilocalorie, and you drink water, the liver fat is gone. And this is fascinating. Intermittent fasting also has a very good effect, but has a mild effect only on the liver fat. Bariatric surgery has a very good effect on body weight, but none on the liver fat. Ketogenic diet has a very good effect on insulin sensitivity, but not on the liver fat. And if we know that 100 grams of fat in our liver makes us becoming a non-responder to physical activity, so we do 10,000 steps, but they only count as 2,000 steps. And we need the physical activity for the other fat compartment. This is the visceral fat. So reducing the visceral fat depot can only be done by physical activity. So let's keep this in mind, how this can happen. So dietary change and fasting is one strategy. There are studies with long-term fasting with less than 800 kilocalories a day. I personally believe this is more difficult. Eating a little is more difficult than eating nothing. And the other option is metabolic surgery. Who can achieve this? I would say all those people with type 2 diabetes up to 10 years after the diagnosis of diabetes. And this is not very precise, because often the diagnosis is a little bit earlier, in other cases it's very late. But our gut feeling from a study with more than 15,000 individuals is if you have 10 years diabetes, you still have a capacity of the beta cell to cope with a remission of diabetes. And it's worth to go for it, because it reduces all the risk factors related to diabetes. It reduces the medication burden, because many of the people after the remission don't need medication anymore. Not only diabetes medication, also blood pressure and lipid medication. And I would say leading to diabetes remission, it's something like you are getting 15 years younger than before. And if we do it with dietary change or fasting, the success story is totally with the patient. It's not us, because we didn't do the fasting. The patient was doing it, and the success story is with the patient. And in terms of self-efficacy, this is brilliant for our patient. But there are also cons. Yeah? If you talk about remission, it's not a cure. You still have risk factors. You still live in a diabesogenic environment. You still live in a toxic food environment if you go to a standard supermarket. You still have genetic risk factors for getting diabetes. And of course, there's a risk of relapse. So after the dietary change or fasting, you have to look into how to change the lifestyle. This is a continuous effort. But taking a pill also means a continuous effort. And if you talk about bariatric surgery, we all know there is also a risk associated with a bariatric surgery. And there's a slightly increased risk of suicides. After bariatric surgery, lifelong the patient have to take medication or vitamins. And there is also a mental burden to this aspect, but there's also a big pro in this case. If we take science and look into the pros and cons, here you see cons is red, the pros is blue. It's clearly worth to go for diabetes remission, whatever strategy we prefer, because I will not say it's a kind of cure, but my gut feeling is a little bit it's a kind of cure if we use strategy leading our patient to diabetes remission. And I want to address the fasting again, because in my eyes, this is one of the innovations in diabetes care in the moment, and the International Diabetes Federation is very committed to this topic. We know eating less is healthy. You live longer, it's good for your genes, it's good for your brain, and so on. So having a certain healthy diet is healthy. So maybe we can propose eating nothing for 2 weeks is even more healthy. And it has a cool effect. You lose a lot of weight. Not all the weight you lose is fat. Some part is fluid and you retain this. But you have a complete reset of your microbiome and you abolish your liver fat. If you had about 200 grams of fat in the liver, you can totally abolish this with 2 weeks fasting. Is this a strategy worth to go for? Here you see glucose red and blue ketone bodies, a slim individual and an obese individual. On my side, it's a slim one and the other one is obese. And you see, it looks like in terms of the race of ketone bodies that fasting becomes more efficient in obese individuals. This is also some cool information because this could be the right way to tackle also the obesity pandemic. An ambulatory glucose profile, we just had some information about the sensors, and the bold printed line on top is an average about 14 days for someone after fasting, and you see a totally flat glucose curve, and this means remission of diabetes. And here is MRI spectroscopy, a picture. The cloudy stuff in the liver is the fat in the liver, and this is before the fasting, and this is after the fasting. So in my eyes, this is remission of diabetes. It's not truly remission of diabetes, it's remission of fat content in the liver, but this is the main determinant for the development of diabetes, and by this, it's also remission of diabetes. And the International Diabetes Federation is very clear in this, that lifestyle intervention, intensive lifestyle intervention, fasting, also intermittent fasting and different other fasting styles, this could be a clear add-on to our portfolio in diabetes management. As diabetologists, we are not only drug dealers, I apologize for this word, but sometimes we feel like this. And so there are multiple other options we also have to put into our portfolio. Why is fasting so cool? It mobilizes energy, it produces ketones because the fat is broken down to ketones. And 100 grams of ketones to 100 grams of glucose, the ketones contain 80% more energy than glucose. So it's actually a cool fuel. And it's our hormone. As endocrinologists, we always talk about insulin, but the stepbrother of insulin is glucagon. And it's a much more sexy hormone compared to insulin because it has much more functions than insulin. The glucagon can break down, if you stop eating, breaking down glycogen to glucose. But it also can break down protein to glucose. And what is protein in fasting? It's muscle, and this is bad. So if you fast and lay in bed, you break down your muscle and you increase cardiovascular risk. This is bad. But if you fast and you are physically active, a muscle which is used is not broken down, so then the glucagon is there but cannot break down muscle to glucose. So what is the next option? Is beta oxidation of fatty acids. So it can break down fat to make ketones out of it. And where is the glucagon present? In the pancreas, in the liver. So we can use our genetic inherited power of evolution to lead to diabetes remission. And it's not my idea. Muriel has found it more than 50 years ago, that the glucagon is the hormone of ketosis to break down fat in pancreas and the liver. And there is a lot of power we can associate with fasting in different kind of fasting styles: insulin sensitivity, glucose fat metabolism, A1C, blood pressure, cardiovascular risk, weight loss, and remission of diabetes. And here it's written 60%. It's maybe a little bit optimistic. We would say it's about 55%, but there are a lot of big trials ongoing. So this, in my eyes, is remission of diabetes. And it's inherited in every one of our culture. I would say it makes sense that all the monotheistic religions put fasting once a year into their schedule. Yeah, of course, it has a religious purpose, but as an agnostic physician, or let's think as an agnostic physician, it doesn't matter why you are fasting. The medical consequence of the fasting is always the same. So it is good to fast once a year, and this might lead to diabetes remission. So intermittent fasting, total fasting, water diet, fasting mimicking diet developed by Walter de Longo in LA and now in Italy. This is something tackling the roots of diabetes development. There are different methods of intermittent fasting, 16 to 8 and 5 to 2. I would say it doesn't matter what kind of intermittent fasting method you are using. If you choose this, it has to fit into your schedule. And also here is the power of lowering A1C, glucose, fat, cardiovascular risk, and energy metabolism. And coming to the water fasting again, it's more aggressive, but it's more shorter. And it might be an opportunity for people living with diabetes saying, yeah, I cannot change my lifestyle for 3 years, but to be totally committed for 2 weeks and then go ahead with an intermittent fasting style or a low carb diet, this is an opportunity. And we have very good results. I see the time is already slightly over. This was the initial thought or the title of the question. So what is the answer? Is it overpromised or underutilized? And I clearly would say it's underutilized. But we also have to be careful. Yeah? If I'm fascinated by the fasting, yeah? And maybe I'm also over-optimistic. Yeah? We have to be careful in looking for the people living with diabetes who can fast. We have to monitor it. And as more patients we have, as more side effects will also come up. So it should be a tool in our hand. I totally agree that someone who's healthy, they can decide to fast and do it themselves and fine. But someone who has medications, someone who has a chronic disease, should be looking at it. So underutilized, but we should not overpromise. The International Diabetes Federation has launched a group on fasting and diabetes. We will launch in about 1 year from now a guideline on 19 different fasting styles for diabetes. And for me, the fasting is the most innovative innovation in diabetes care in the moment for the remission of diabetes. Finally, IDF. Do we need IDF? Of course, we need a powerful voice for people living with diabetes and for us to treat these people living with diabetes, because they have the right to have the same quality of accessibility and availability of diabetes care. As president of IDF, I have 3 goals: to be in the brain of the politician, in the pocket of the patient, in the heart of the healthcare professionals. Global Diabetes Index is for the brain. A free diabetes education app in the pocket of the patient is for the pocket of the patient, for anyone worldwide. And finally, the fellowship program for you as healthcare professionals of IDS is for the heart of the healthcare professional. 75 years organization. It's not old, it's an experienced organization. Let's work together using social media, using all the channels available, looking into the faces of people living with diabetes, because they deserve a better quality of life. Let's work together to help them finally walk away from diabetes. Thank you very much.